Good afternoon, everyone. My name is Mary Malik, and I'm a provisional counsellor currently completing my placement at the Mental Health Foundation Australia. I'm honoured to be your host today for today's webinar. I would like to be acknowledging the Wurundjeri Woi Wurrung people as the traditional custodians of the land on which I live and work on. I pay my deepest respects to the elders, past, present, and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. On behalf of the Mental Health Foundation Australia, I warmly welcome you and thank you for joining us for today's session, Adverse Childhood Experiences and Mental Health. This is an important and timely conversation, and we are grateful to have you here as we explore the lasting impact of early life experiences and the pathways to recovery and emotional strength. So let's get started. It's now my pleasure to invite our presenter, Professor Melissa Green, to share her insights with us. Professor Green is a distinguished researcher and a professor at the University of New South Wales, Sydney, in the discipline of psychiatry and mental health. Her work focuses on developmental risk factors for mental health disorders, including childhood trauma and other adversities, and she has a special interest in psychosis and suicide prevention. She currently serves as the Director of Research in the School of Clinical Medicine at UNSW and leads the New South Wales Child Development Study, a longitudinal study of more than 91,000 children growing up in New South Wales, conducted in collaboration with the multiple government departments and other academic in Australia and New Zealand to understand the early life factors that shape mental health outcomes. Her contributions to the field have been recognized internationally, including fellowships from the Rockefeller Foundation and the Royal Netherlands Academy of Arts and Sciences. Please join me in welcoming Professor Melissa Green.
Thank you very much. Can everybody hear me okay? I'll keep going. It's my pleasure to be here today, and I thank the Mental Health Foundation Australia for inviting me to present this afternoon. As you've heard, I'm going to be speaking about adverse childhood experiences and mental health, and I just want to draw your attention to the website that I've got on this opening slide. A lot of the work that I'll be presenting is summarised on that website, and so if you miss some detail, I'd urge you to follow up by going to that website and having a look at the summaries that we have of all of our projects there that can help you if you are interested in more information. So without further ado, I'm just going to start with a bit of background. And I think it's common knowledge that the mental health of young people in Australia is declining, and it has been for over 10 years. This graph is from the Household Income and Labour Dynamics in Australia survey, or the HILDA survey, that's showing a mental health measure by age group over time. And you can see that from around 2010 onwards, this dark blue line down the bottom here are children aged 15 to 24 years. And while everybody's mental health is clearly declining some more than others, that group there, the 15 to 25-year-olds, has the steepest decline over that period, followed by people aged 25 to 34. This is also reflected in our national study of mental health and wellbeing. The last one was conducted in 2020 to 22, and that one showed that more than 38% of people aged 16 to 24 had some symptom of mental disorder in the past 12 months, which was an increase from a 26% that was previously recorded in the survey prior. Sorry, are you seeing all of that? The rise in the prevalence is more marked in young women, and we see that in rates of self-harm, which are higher in females than in males. So these data ended in 2020 in that graph, And when I went to look up what had happened in the subsequent surveys of the HILDA, they've flipped the measure, which is now reporting distress instead of health. And so the graph is going upwards here, people aged 15 to 24, because they still have an increasing rate and prevalence of psychological distress. So the last data available is from 2023. And we can see that things are potentially slightly improving, but the rates are still very high in these young age groups. Moving to rates of self-harm and suicide, and I've got some data here from the Australian Institute of Health and Welfare. The current statistics are that suicide is the leading cause of death for young people in Australia who are aged 15 to 44. And over 1/3 of deaths in young people aged 15 to 24 years are by suicide. These are alarming rates. And what we do know is that suicide rates are higher among young males. They're higher among Aboriginal and Torres Strait Islander people and among people living in regional and socio-economically deprived communities. Now, in the graphs that I've presented here, over on the left, you can see that rates of self-harm in this light blue line are higher among females aged 15 to 19. So they have the highest rates compared to males who are represented a bit further below in that graph. Whereas on the right-hand side, as I've mentioned, suicide deaths are higher in young males. So while the young women are presenting with self-harm and perhaps suicidal ideation, young men are by far exceeding women in their rates of actual suicide. So again, these are alarming statistics. And when we think about why they might be, we can consider adverse childhood experiences as potential risk factors for poor mental health and suicide and self-harm. Now, when you go to the literature on adverse childhood experiences, it generally refers to child abuse. It could be physical, emotional, or sexual abuse. Neglect in childhood, which might well be physical or emotional, but it also refers to household dysfunction. And I wanted to draw your attention to that category of adverse childhood experiences because household dysfunction primarily relates to parents' behaviors. You can see the things listed are mental illness, having an incarcerated relative, so a parent in jail, having a mother who's treated violently, so having some domestic violence happening in the home, parents who are abusing substances, and or divorce. And so these are generally the list of adverse childhood experiences that are mentioned in literature in America. And my point of pressing this slide is that just to press home that message, that the next generation is affected by their parents' own adverse experiences. So it's not just the experiences of the child, but the experiences that their parents are having. And in which case it means that the propensity for having your own experiences as a child begin even before you're born. They begin as your parents are getting ready to procreate and have children, and the way that they're living their lives, having experiences such as this, mental illness, criminal justice contact, is going to impact a child's own adverse experiences and risk for mental illness. So now I'm going to turn to walk you through some of the studies that we've been doing on this theme within the New South Wales Child Development Study. So this is a large study of over 91,000 children that is conducted via record linkages. This is the profile paper that introduces the cohort. And so if you're interested in the details of how we do the linkage, exactly what kinds of data are linked for children and their parents, this is the source of that information. Just to try to describe it to you here, this is a busy slide, but I'm going to walk you through it. You can see a timeline down below running from 1971 through to 2022. 1971 is the earliest date at which we have parent data for the children's parents. But the children themselves were born between 2002 and 2005, and we have followed those children since they were born all the way through to age 20 years, where we have linked data up to 2022. Now, the couple of other things marked on this slide are the AEDC measure, which was conducted at school entry, and a middle childhood survey, which was conducted when the children were in year 6. So they were about 11 to 12 years old, and they were just about to finish primary school and start secondary school. These two assessments are what are used to define the cohort. So when we think about who we're studying here, we're studying 91,000 kids who either completed the early development census when they started school or they've completed the middle childhood survey when they were in year 6. And you can see in the middle here, there's about 23,000 children who have both measures. But altogether, this cohort is 91,597 kids. And for those cohorts of children and parents, we've linked data from their health records, their child protection service records, from the police, criminal justice records, education, and welfare. So as I mentioned, all of the information about how we do this is summarized in the paper that I showed in the last slide, which you can access via our website. So let's start looking at some of the findings using these data. Let's just start with looking at the mental health of children and adolescents in this cohort. When we look at the use of Medicare subsidized mental health services for this cohort through to age 14 years, we can see here that by age, so this is a cumulative incidence graph, we can see that by age 14 years, 25% of our cohort have accessed at least one service for mental health problems via the Medicare system. So that could be just seeing their GP, it could be seeing a psychologist, or using the Better Access Plan to get psychology sessions, or a psychiatrist, or some other form of mental health assessment or treatment. You can see that by around, again, by 14 years, just under 25% are using the Better Access system for mental health care. Around 17.5% are accessing psychology services, whereas much fewer children are using psychiatrists or social workers. But this shows quite a high rate of mental health service use by age 14 years. Another thing that we've done to try to tap into what kind of services and how children are using for mental health problems in this cohort has been to look at what kinds of drugs children are being prescribed through the PBS, where we have our medications subsidised by the Commonwealth Government, so the Pharmaceutical Benefit Scheme. So in this paper, we restricted the cohort to around 86,000 children. And what we saw, we followed these children all the way through to age 20, and 30% of them had been prescribed at least one psychotropic medication for a mental disorder by age 20 years. You can see in this graph, in the table down the bottom, that the highest rates of individual types of prescriptions were for antidepressants, where 24% of kids or young people were prescribed an antidepressant, and 10% were prescribed stimulants as another highly prescribed medication. You can see on the bottom row the number of prescriptions. So even though it's only 10% of the cohort being prescribed stimulants for ADHD typically, the number of those prescriptions is quite huge, more than 300,000 prescriptions for that 10% of the population. When we analyze these data over the cumulative period from birth to age 20, what we see are represented in these graphs below. So over on the left, you have the annual incidence in terms of the annual number of children with a prescribed medication of different types over the age bands represented there. And on the right, it's the same data, but presented as a cumulative incidence graph. So what we can see is what I showed you earlier in the table, that more than 30% of kids by age 20 have any psychotropic medication. But we can see that those medications start being used at very early ages. They're starting around age 5 to 6 years of age, and they're just increasing onwards since that time. Stimulants are starting that early as well. They're sort of petering out without a rapid increase through adolescence. But where we see a rapid increase through adolescence is the use of antidepressants. So all of these data are just describing what I already showed you from that AIHW and national statistics. The mental health of young people in this country is alarmingly poor, and these rates of medication use are actually well higher than similar age groups in European countries of the same economic standing as Australia. So we have a problem in this country with mental disorder. So let's talk now about how childhood maltreatment might be impacting those statistics. I just wanted to start by mentioning the Australian Child Maltreatment Study, which used surveys to interview 8,500 people in Australia. The age band for children aged 16 to 24 captured about 3,500 young people. And they were asked about their different types of childhood experiences of 5 types of maltreatment. Those statistics are down below, where around 30% of people reported experiencing physical abuse or sexual abuse or emotional abuse in their childhood. Around 8.9% experienced neglect, and an alarming nearly 40% are being exposed to domestic violence in their childhood. So these are self-report data, and they can often overinflate estimates of child maltreatment versus data that I'm about to tell you, which will underrepresent child maltreatment due to the need to be reporting those experiences to child protection services. But before I go and show you those rates, I wanted to just point out that a study that used those data that were generated in the Australian Child Maltreatment Study tried to estimate what the proportion of mental disorders in Australia and suicide in Australia, what proportion might be attributable to childhood maltreatment. And this was published just last year and suggests that over 21% of cases with depression and over 41% of cases with suicide attempts could be attributed to child maltreatment based on the rates of maltreatment reported in that Australian Child Maltreatment Study and the rates of mental disorder in Australia. So this is another piece of evidence suggesting that we follow up on earlier experiences of child maltreatment when we're thinking about how to prevent mental illness in young people. So moving to the rates of child protection service use as a proxy for maltreatment within the New South Wales Child Development Study cohort, what we have found is that by age 18 years, 1 in 3 children have had some contact with child protection services. So that's similar. Around 30% of these young people are are recorded in child protection services, similar to the 30% that was recorded in the survey of the Australian Child Maltreatment Study. Now, 1 in 4 of these children actually met a threshold for risk of significant harm, which means that their report is deemed worthy for follow-up by child protection caseworkers. If they are followed up by caseworkers, their report can be substantiated, and we found that 1 in 15 people had a substantiated child protection report. So it's reached that risk of significant harm, it's been followed up, and it's been substantiated as a true case of maltreatment. And 1 in 33%, so it's only around 2.6% of the population, are placed in out-of-home care by the age of 18. So they're the rates in our child protection data. Now, when we look at the association between child protection service contact and mental disorders in early childhood, So this is limited to mental disorders that are found in children up to the age of 13 years, actually between the age of 6 and 13. And the child protection reports in this group were before age 6. So we've got reports of child protection up to age 6, what kind of mental disorders afterwards. And what we find is that 1 in 10 children known to child protection services have a mental disorder diagnosed in their health records by the age of 13. And that's in comparison to only 1 in 33 of the children who don't have any child protection contact who have a mental diagnosis by age 13. Now, taking this a little bit further, where we have broken down the child protection data now into the child's highest level of response. So a child, if they've been placed in out-of-home care at all, they're in the out-of-home care group in this analysis. If they've had their child protection report substantiated as the highest level of protection they've had from that service, then they're in the substantiated risk of significant harm group. If that reports to child protection have not been substantiated, they're in the green group, the non-substantiated risk of significant harm. Or they could have a report that was not substantiated, didn't reach the threshold. They're in blue, and we've got people represented in pink who have no contact with child protection at all. And again, I've got one of these cumulative incidence graphs where we're looking over time from the years of age 10 through to age 17. How are these rates of mental disorder increasing in each of these groups of children with their different contact with child protection services? And as you can see pretty clearly, those who have been placed in out-of-home care at any time, by age 17, it's 30% or over 30% of those children are diagnosed with a mental disorder. And you can see that the rates for all other children known to child protection services are similarly higher than those with no contact with child protection services, but obviously increasing in that stepwise fashion. So the higher your level of contact with child protection services, which we take as a proxy for how severe your maltreatment experiences would be, so the higher that level of response, the greater likelihood of having a mental disorder diagnosis by the age of 17 years. Now, these graphs are showing the same type of information, but for different types of mental disorders, so different categories of disorder. And I wanted to just point out a couple of things here. I want to point out firstly, just to make sure you realize that the cumulative incidence is on a different scale on each of these graphs. So psychotic disorder is quite rare. There's only 1.5% of the population who have those disorders by age 17, but you can see the sharp increase for psychotic disorders among those who are in out-of-home care and among those with substantiated child protection reports from age 15 onwards. Other groups have a slow and steady increase from about age 13, but these two groups are at very high risk of psychotic disorder in their later adolescent years. I want to compare that. Let's come back over to the first graph, the developmental disorder graph, where from age 10, we've got slow and steady increases of diagnoses with developmental disorders, things like autism and ADHD. And they are, as per the graph on the previous page, increasing with the level of child protection response, but in that slow graded increase, which is similar for anxiety disorders. Depressive disorders start to kick in at around age 12, and substance use disorders at around age 13. So we have a few more disorders summarized in the manuscript for this paper, but I didn't want to show all of them. It would have been far too busy. It's busy enough as it is. But that just shows you some of the differences in the onset time and proportion of children with each of those child protection responses with different disorders by the age of 17 years. Now I want to move to some work that was done by a postdoc in our team, Kirsty O'Hare, and she looked at self-harm and suicidal ideation, particularly among children known to child protection services, And this was using data up to the age of 17 years. And what we could see was that there were around 2,300 children who had a first incident of self-harm or suicidal ideation recorded in any of their health data collections up to age 17 years. And again, in this study, we used that characterization of children within child protection services according to their highest level of contact. But before I show you another cumulative incidence graph, I just want to go over to the right-hand side of this slide, where a very simple figure depicts one of the alarming rates of child protection service use among kids who have an incident of self-harm or suicidal ideation recorded in their health service use data. So what you can see is there that 75% of children who had any self-harm or suicidal ideation recorded also had child protection incidents recorded in the New South Wales Child Story database from DCJ. And now when we look at the rates according to the highest level of service provided by the child protection services, it's a similar story to all of those other mental disorder categories that I showed you in previous slides. What we can see is that by age 17 years, 13% of kids known to child protection who have been placed in out-of-home care are being recorded as having a self-harm or suicidal ideation incident, versus around 10% of kids in the substantiated group, versus around 4%, 5% of kids in the non-substantiated group, and less than 1% of kids in the group that have had no contact with child protection services. So once again, just a very clear dose-dependent response of having higher levels of service by child protection and the increase in risk of suicide, suicidal ideation and self-harm. So let's just go back to these adverse childhood experiences that I've mentioned, because so far we've only been talking about these abuse and neglect measures where we're talking about direct experiences of the child. But as I mentioned at the beginning of the talk, the next generation is affected by their parents' experiences. And so when we measure ACEs or adverse childhood experiences, we often measure extra things like whether their parents are have been diagnosed with a mental illness, or whether their parents are in contact with the criminal justice system, exposed to domestic violence, etc. So I'm just going to talk through a few studies now that have looked at that expanded sort of definition of adverse childhood experiences beyond child maltreatment and the Child Protection Agency data. And so when we look at these kinds of data, we can draw from all of the range that I mentioned at the start. We've got our wellbeing indices, health data, socio-demographic indices, where we can access people's socioeconomic level, how remote their environment that they live in, whether they're accessing welfare benefits. And we can look at criminal justice contacts of parents as a victim, criminal justice contacts in terms of court appearances or custody periods. And we can also look at the child's contact with police as a victim, a witness, or a person of interest. So the first study that I want to talk through was again led by Kirsty O'Hare. And this was conducted when the children were only 13 years of age. And so the number of children reporting self-harm was much lower at that period of time. So when we had only wave 2 data collected up to age 13, we only have 132 kids, as opposed to, I mentioned before, 2,500 or 2,300 by the time they were 17. But for now, we've got a very small sample of kids with a self-harm recorded in their health records. And what we wanted to do was just look at their parent risk factors. So there's a list here on the right-hand side of parent mental disorder types, and also whether the parents had any imprisonment history, any history of violent offending, or any record of either offending or mental disorder. And we also looked at some community risk factors. We looked at neighbourhood socioeconomic deprivation, so based on the area of living. We looked at remote or regional location in terms of where the people were living. And we also looked at high neighbourhood crime rates. And so this is a very busy slide, and I'm just going to help you draw your attention to the things that I want you to pay attention to. So this, marked in yellow, are the associations between each one of these listed risk factors of the parents or the community and their child's self-harm report. And so these are unadjusted odds ratios. And what they show are that parents' mental disorders are very strongly related with having a child who's self-harming, as are parents' contacts with justice systems, whereas the community risk factors are having small, if at all, these ones aren't significant, the socioeconomic deprivation and the crime rate, but living in a remote or regional location is having a small but significant effect on the child's self-harm reports. Now moving to look at a different part of this slide, I wanted just to show that when you factor in child maltreatment, which is far over there on the right-hand side, and you can see the odds ratios of that variable are now exceeding those that were originally generated for parent risk factors and community risk factors, and that the parent risk factors have now dropped in their odds ratio strength, showing us that even though these parent risk factors are playing a role, the child maltreatment is playing a bigger role when everything is considered at once. I think that's all I want to say about this, because it's very complicated in terms of how many pieces of data are there. And that's the message I want you to take from it. Yes, parents, mental disorders are important, but actually they're trumped by the child's own maltreatment experiences. And now I want to move to an even more complex study and talk through the results from our newest linkage, where we're back to having more than 2,000 children who have reported suicidal ideation or self-harm, and it's been recorded in their health or other records. And in this study, what Oliver Watkins is doing, he's a postdoctoral research fellow in our team, and he led this one. He's tried to show how the regional occurrence of adverse experiences in the state of New South Wales. He's asked the question of whether those experiences of adversity are related to the rates of suicidal ideation and self-harm in this group of kids in our child development study. So I've listed down the bottom of this slide a very long list of adverse experiences that actually go well beyond maltreatment, as we've discussed, to include the parent's mental disorder, the parent's receipt of welfare, which is getting at a proxy for not poverty, not extreme poverty, but definitely economic stress. We've got whether the child has their own criminal charges, whether mum or dad has criminal charges, whether the child themselves has been incarcerated as an adverse experience, or whether mum and dad have been incarcerated. We've got parental death. We've got their child's own child protection contact. We've got the child's placement in out-of-home care. And we've got the child's contact with police as either a victim, a witness, or a person of interest, all counted separately. So what Oliver did was take all of these adverse experiences and basically tally them up. How many do children have? And then when we then look at the postcode where the children are living, what are the rates of these adverse experiences spread across New South Wales? And here's the map of that first step. What you can see really clearly is that young people who are growing up in regions outside of Greater Sydney, which is represented down here in this very small area, but particularly children growing up in northwestern New South Wales, and all along the coast, the North Coast as well. So it's not just the inner rural western regions, but northwestern coast. These children are showing the greatest exposure to early childhood adverse experiences. And they're also the children who are living in the highest proportion of, those regions have the highest proportion of children living in socioeconomically disadvantaged areas, and they're also geographically remote areas. Now, what do you think happened when Oliver does another map looking at the rates of suicidal ideation and self-harm? Well, that map looks like this over on the right-hand side, where rates of suicidal ideation and self-harm are closely mapped to the rates of adversity that were seen in these children across the state of New South Wales. It's not an identical map, but you can see that the, overall, you can see the colours showing a similar pattern, whether it's ACEs or adolescent self-harm or suicidal ideation. When we actually analyse the associations between those things, we get this little graph here. So there's a set of regions over here. I'm just going to ignore them for a minute. There's some parts of Sydney that have a very odd association that isn't in line with this association here. So outside of Sydney in green dots, and in the inner west of Sydney and outer southwestern regions of Sydney, you can see a clear line, what you would see in a regression, where as the incidence of ACEs increases, as does the incidence of self-harm and suicidal ideation. What's going on over here in these other outer regions of Sydney, we're not sure, or sorry, they're probably even very inner city regions. But it's still of interest to note that in general, as adverse childhood experiences increase, so does adolescent self-harm and suicidal ideation. And I haven't shown the graphs here because there were, again, I didn't want to overwhelm you with too many pieces of complex information. But what we saw here was that both the adverse experiences and the suicidal ideation and self-harm were high. There were higher rates in the regions that have socioeconomically deprived areas and in the remote and regional areas of New South Wales. So there's a couple of papers here that I haven't shown you that I just wanted to, it looks like I did have time, but I was worried I was going to run out of time. But we have done other work where we have looked at the conditions of birth that children are born under and their outcomes across a range of social, educational, and health outcomes. And what we see in that paper is that you can very highly predict children's childhood contact with child protection services from what you know about a family when a child's born. In this other second paper that I've listed, similar kind of work that Oliver did, where he looked at clusters of families at birth and how the risk factors and how they cluster together and then predict later outcomes. And again, there's a certain pattern of outcomes, a certain pattern of risk factors that are evident in a family at birth that are highly predictive of outcomes in childhood. And then the last thing that I probably should have unpacked a bit more, but I'm happy to speak about it further, is that we have also looked at resilience among kids who've been experiencing maltreatment. And that was a study that we did only up until age 13 years, where we looked at patterns of socio-emotional functioning over time among kids known to child protection services. And in fact, we found that quite a high proportion are able to either recover their social emotional functioning over time, or they actually didn't ever have any impairment. And of course, social emotional functioning is so important for developing skills that ward off mental illness in later life. And so that study is one of the ones that we've done to try to highlight what kinds of characteristics children have that make them resilient to these adversities in childhood. And interestingly, it was um, these characteristics of these children were actually to do with their openness to experiences. So things about their personality style, openness, um, and also, though, not being subjected to very severe maltreatment. So have a look at that paper if you're interested. And as I said, all of these are available on our website. So just to start closing up, what you've seen in my presentation today is that the mental health of young people in Australia is poor and prescription medication use is very high in our country. You've also seen that child maltreatment is highly prevalent and has a strong impact on mental health outcomes in children and young people, but also that adverse childhood experiences extend beyond direct maltreatment and include the experiences of parents. You've also seen that the cumulative adversity in childhood is more prevalent in regional areas, alongside higher rates of self-harm and suicidal ideation in young people. So what does this all mean for how do we do anything about youth mental health? How can we improve it? We think that addressing intergenerational risk factors would be a good way to go. This is because mental ill health and suicide prevention isn't only the responsibility of health services. We see evidence of these incidents in child protection reports, in police reports, and in other data, not just in health service data. And so if we could have a whole of government approach where each agency was involved in doing its bit to prevent suicide and prevent mental ill health through cooperation and programs that made sure they were joined up for people in the community, rather than people not knowing where to get assistance, being fobbed off from one agency to another, we think that that would be helpful in the long term. We think that within those kinds of interagency programs, the targets for prevention should be parental adversities as much as the child's own early experiences of maltreatment and other adversities. So we have to think across generations if we want to make any impact on these issues. We have to think about reducing mental illness in young adults before they become parents, so that they begin the new life cycle on the best footing for their offspring, and bring their children up into a place that has good support network, good communities, rather than being exposed to a bunch of parental adversities that really have impact across generations. And to do this, we think that staff working in child protection services and the police force most predominantly should be adequately addressed to respond to incidents of self-harm and suicidal ideation in the community, but also other incidents of mental health problems that child protection agencies are privy to in those children's early years of life. They're also privy to domestic violence in families. So all of this corresponds with an approach that is well recognised by the World Health Organization. It's focused on the social determinants of mental health, and it takes a life course approach to tackling inequities in health across generations. So while this figure is showing this life course of one person from prenatal through to their early years, their working age, their older ages, any negative experiences which accumulate over that life course are pretty much, regenerated around to the next generation. And this cycle just keeps going without adequate prevention mechanisms that are going to have to include things like broader systems to do with our health, our economics, at a context that involves pretty much the whole of government, which is why in my implications slide, we've talked about a whole of government approach. So to do this, we need all agencies on board. We need society to understand that adverse experiences aren't just something that happen and go away. They have an accumulation of effects over your life course and over the next generation's life course. So if we want to break this cycle of transmission of both adversity and mental ill health, then we have to look at these wider systems and how we can improve the early life course of everyone to ensure that they have the best chance for development and mental health. So I'll just end here by acknowledging the data custodians for the New South Wales Child Development Study. There's a long list there. I'm not going to read them all out, but I want to just make sure that you're aware none of the findings that I've reported here necessarily represent the views of those agencies or the people working there. And I just want to acknowledge the big team that works on the child development study. I could not do this work without the help of all of these people. Particular shout out to Professor Vaughan Carr, who began the study more than 20 years ago, and a range of people that are listed here who have been involved or are involved currently in the work that we do. So thank you very much. I'm happy to take questions.
Thank you, Professor Green, for delivering such a compelling and informative presentation on the adverse childhood experiences and mental health. Your expertise and thoughtful insights have greatly enriched today's session. We do now have time for some questions, and if anyone has not already, please feel free to type your questions into the chat box. I'll do my best to get through all of them. We do already have the first question, and so I'm just going to read it out for you. So the data that reflects a decline in mental health, has this also considered better reporting and improved awareness of mental health services, proactive interventions?
I'm just trying to understand the question. The data that has reflected the decline has come from the government or surveys done by community groups or surveys done like the Hilda survey. So has that considered better reporting and improved awareness? I'm not sure whether those surveys have considered those things. I think we've had a lot of increased awareness of mental health problems in the community over the last 15 to 20 years. And so if that's the point of this question, asking whether more awareness has basically made it look like we've got a steeper decline in mental health, that is possible, but I doubt it, considering like that it can be the full explanation when you're using government data like health services and PBS prescriptions, when you're not using, you're not relying on people's surveys for that data. You're basically looking at who's using services for mental health. I think I'll stop there.
Thank you. Moving on to the next question. As a social worker, what are the key strategies we could take in our practice to address this issue?
Yes, very important to think about how each of us can do our bit. As a social worker, I mean, I guess you would do this already, but making sure that you have all of the information about a person's context, taking that information without judgment. There are instances of domestic violence. There are male and female perpetrators. There are reasons why people are engaging in these kinds of behaviors, usually under severe economic stress. So I would just suggest taking into account all of the types of adversities that you've heard about here today and trying to ensure that you're aware of any future adversities that could still be going to have effects on the people that you're helping. And yeah, basically just trying to do that with a holistic and non-judgmental approach.
Thank you. Moving on to the next question. In the child development study, are there any considerations or qualitative studies on the experiences of children and parents as they went through different service agencies?
So that's a good question as well. And we've started some of those studies in the past and they've actually never been finished. Um, but it's something that we want to pick up on again. We talk about these things all the time with our Aboriginal reference groups and our lived experience groups. But obviously, the data that I've shown you is based solely on government reporting. And so I have no data that I can speak to about those qualitative experiences, but we are very well aware of the importance of those. And it's the way we think about how to interpret our data when we talk to our Aboriginal and lived experience groups. We're often reflecting on what somebody's experience was and why they might have seen three different health services before they got any assistance. So thank you for that question because it's very important to always contextualize this sort of hard, crude data um, against the experiences that people have.
Thank you. There's just a comment here saying, I noticed that LGBTIQA plus young people were not mentioned in regards to extremely high risk of having mental health issues and high suicide rate of suicide.
Yes, and so I'm glad that you've raised this one. It's unfortunately one of the limitations of linked data in this country, where all the information that we have around somebody's gender is their assigned sex at birth. And there's nowhere in the data where it's been recorded as to whether anyone identifies as LGBTQIA. And so there's just no information. There are other groups, such as those at the Black Dog Institute, who are using surveys in schools and asking questions around these kinds of things to young people. And so it's good that you've pulled me up. I didn't mention it because we have no data, but yes, those people are at extremely high risk of mental health problems and high rates of suicide.
Thank you. That's the last question here. Have you thought a bit on how to be proactive or prevent this issue rather than reactive?
Yes, indeed. That's what I'm always thinking about. I often wonder how many more psychology services we can have, because that's usually the answer that people want more and more services rather than thinking about, hang on, why do we need so many services? What is going on? And why do we need to, what do we need to do to prevent? And so that really was why I talked about some of the social determinants, which are broader than any individual, and things like preventing adversity over generations as one of the ways we can try to prevent the need for all these services and reactive approaches. So I'm absolutely on board with trying to, I went to say get in early, but whenever I say that now, I think about how it's not even getting in early, for which generation, we have to get in, yes, as early as possible for every individual and make sure we're monitoring risk and providing supports when people need them. But over generations is really now for me the way that I can see some light at the end of this tunnel. If we can start reducing adversity on a range of issues, we should, I hope, see some decline in the rates of mental health problems in these young populations.
Thank you for that, Professor Green, and thank you for all the thoughtful questions. And special thanks to our presenter and all the insightful and generous responses. Don't see any more questions here, but if we didn't get to your question today, we encourage you to follow up via an email or explore the resources that we'll be sharing after the session. Thank you, Professor Green, for answering all the questions from our audience and for your excellent presentation. And thank you to everyone who has joined us today for this vital conversation on adverse childhood experiences and mental health. It's been a privilege to share this space with you, and we hope the insights and reflections offered today have inspired deeper understanding and empathy, both personally and professionally. On behalf of the Mental Health Foundation Australia, I'd like to extend our heartfelt gratitude to our speaker and to each of you for your time, attention, and dedication to the mental health advocacy. We encourage you to continue exploring this topic and stay connected with our community. Thank you so much. Until next time, take care of yourselves and each other. Thank you.
Thanks very much.
Goodbye.